welcome to Perito Talk, our occasional conversation with men and women who matter. We now continue our talk with Dr. Sudha Seshayyan, a former anatomy professor, currently Vice-Chancellor of the Dr. MGR Medical University, and a very, very well-known name in the Tamil literary circuit. Dr. Sudha, we would now like to talk to you about medical education.
Yes.
First up, the most critical question that many people are asking is, there is CBME. We would like the viewers to know what it is and what change has it brought about to the education.
Fine. CBME is competency-based medical education. Now, in 2019, starting with the 2019-20 batch, the batch which got admitted in MBBS in the year 2019, the National Medical Commission and the erstwhile Medical Council of India had advocated the CBME curriculum for all those who joined the undergraduate medical education program in the country. Now, you may ask me as to what was the necessity to get the CBME in place. The medical curriculum, or whatever curriculum that leads to the MBBS degree or the basic medical degree, the Indian medical graduate. When the Indian medical graduate emerges out of medical education school, will have to be competent enough to handle a patient. Now, this is what is the objective. Over the course of time, this had been the objective, and time and again, we had been revising our curriculum for the simple reason that there had been lots of changes in the medical education component itself, lots of scientific advancements and so on. But last 50 years or so, medical education, on one side, there were several advancements, but then the syllabus part of it or the curriculum part of it was not totally redesigned. You know, when we were students, I'll put it in comparative terms. When we were students 40 years ago, what should you learn? You should learn everything about the human body. Now, everything about the human body kept on expanding. So on one side, the material to get in has increased. On the other side, the time has reduced, the total duration has reduced a little, and other interests have come. Other interest in the sense, earlier, 40 years ago, somebody graduates with an MBBS would only be become a family physician, go to his village or go to his rural town and become a doctor there. But things have advanced to that level that somebody cannot stop with MBBS only these days. They would have to either go to MDMS, even that is considered very basic. They would have to go to DMMCH and so on. So in the bargain, what happened was, a student, an average student's concentration was to get into these doors, get into the door of MDMS or the door of DMMCH. So the concentration kind of shifted. As you're studying for your MBBS, you also want to qualify for that. So your concentration on acquiring practical hands-on knowledge reduced.
Are you saying that in the second, third year, they started focusing on writing the PG exam?
Yes, okay. It happened. So a kind of redesigning of the curriculum, try and take what is required for the Indian medical graduate, because there could be diseases happening across the globe, but certain things will not happen here, certain things will happen in a different part of geography. So all this had to be taken into account. A complete redesigning of the curriculum was required on one side. On the other side, emphasis on hands-on acquiring competency. So this brought the competency-based medical education curriculum. For redesigning itself, it took about 2 decades. It was not just, not done in 2-3 years' time. Certain things had to be pruned, certain things had to be included, but then the last 3-4 years were crucial. Just before 2019, last 3-4 years, the Board of Governors, the erstwhile MCI, the expert committee, all that sat down and brought in several things into the curriculum. One example would be computer education. Computer education was not part of the medical curriculum at some, even 10 years ago. But now computer skills are basically required. Then some amount of soft skills. In the first part, we were talking about, does a doctor talk to the patient at all? Now in CBME, soft skills, communication skills have become important. The orientation of talking to a patient. How should you handle a patient? A patient who's quite well informed, a patient who's adept with social media, would know things, with that, how do you handle a patient? Or if you would have to break a bad news, how do you talk to them? What kind of reaction do you expect? Like, patients are most of the time in some grief or some misery or some difficulty or in some pain. Even if you take someone comes to you with a common cold, they have some kind of difficulty and pain. So you cannot expect them to react the way a normal individual would react without any pain or anything. So these things will have to be brought into the curriculum. The student will have to be trained. Maybe these things appear to be a little out of curriculum. Can all these be taught? But then at least they have to be trained as to how to face a patient or how to talk to them, or be tolerant at times to certain things, be tolerant to a kind of an extreme reaction. At the same time, stand up also with firmness to reveal what should be revealed. So all this comes into the curriculum, and that is what is CBME. And CBME emphasizes on acquiring competency. Say, for example, we used to study in physiology right in first year, everyone used to study about blood pressure, taking the blood pressure, drawing blood. All this would be studied. But then over the course of time, with number of students increasing and number of faculty members not available for certain supervisory work. So what had happened was, everyone will study about the theory of blood pressure or know that a sphygmomanometer is present, but not probably know exactly at the first year level as to what should be done to acquire the blood pressure details. So now CBME is emphasizing on acquire this competency. Only if this competency has been acquired, a candidate can be certified to proceed further. So competency acquisition has gained more importance. Clinical exposure early, right at first year. Those days, first year candidates would never come across the patient. They would somewhere be away. But now early clinical exposure, soft skills, communication skills. At the same time, psychological balance of the doctor also. This Indian medical graduate will become a doctor eventually, and he or she requires some kind of psychological balance. So that yoga therapy for their own selves, get some co-curricular activity, get involved in that, do your yoga, you internally balance yourself before you face a situation of misery. So all this has been brought into this CBME.
So am I therefore right in saying that the focus is now more on the skill than on the knowledge? Would that be broadly right?
Yes, more on the skill.
The second question is, there have been lots of colleges that have come up, medical colleges. We recently also had this, media glare on doctors, Indian doctors or Indian medical students studying abroad and coming back to India. That's just a point just to be kept aside. What do you think is the quality of the doctors who now come out? All said and done, they spend so many years. You said 4 years of medicine, 1 year of house surgery, maybe 2 years of PG, then 3 years of specialty. They're literally spending 10 years out there. What is the quality of their coming? And B, are the rewards commensurate with that kind of study for everybody?
The quality is good. 4.5 years of basic MBBS plus 1 year of internship, then 3 years of MD or MS, and then DMMCH, once again 3 years. Now, the quality is good. Quality is not compromised at all, in the sense, number of seats have increased. Number of UG seats, number of PG seats have increased. So because of which you find quite a number of them coming out, the competition is increased. Because the competition is increased, a natural edge over, like, whenever something becomes competitive, the quality also goes up. So that way the quality is good, but our candidates are able to perform well even when they go abroad. That is what we see. Anyone going abroad also, they are able to compete well, or even sometimes excel. They are better than candidates in the United States or even the United Kingdom. So that way our standards are good. But the point that many colleges have come up, many institutions have come up, the number of colleges I think I remember 30 years ago, it was just about 100 and odd. And today you have, even in Tamilnadu, our own university has about 51 medical colleges, so that way the number of colleges have increased. But we need to have certain accreditation processes which are already in place. A medical college is just not flagged off. There are certain procedures that they need to follow. Certain check mechanisms are there. This number of laboratories, this amount of infrastructure. And one thing, medical colleges are not just like that left. Once a license is given, it is not that they have a permanent license, but then the check mechanism is periodically put in place and compliance is sought. So that way, this accreditation process which goes on, the National Medical Commission inspects, the local university inspects. So we have several check mechanisms. Despite these check mechanisms, there are certain lapses in certain places. But then very soon, within about 2 years or so, those lapses are also rectified, or at least that college is stamped down. Like, you cannot make an admission. You will have to rectify. Unless you rectify, it will not be cleared. So that kind of a check and balance is continually going on. That will keep the colleges in proper position.
In your view, is this an expensive education for somebody to take up?
Right now, if someone is getting admitted into what are called the government quota seats or the government medical colleges, it is not expensive at all. But when it is, certain self-financing institutions where they would have to generate funds for their running the institution, probably it becomes expensive. And of course, we know there are fluctuations here and there. But if someone is able to get a seat in the government setup, it is not expensive at all. In fact, it is much less expensive than someone who would pursue what we call as humanities or arts and science courses. I remember even when I studied, the total amount that I spent on my 5.5 years, those days it was 5.5 years. So 5.5 years was just about 2,000 rupees, the fee payment put together for all the 5.5 years. Whereas my own cousin who was studying a BA course elsewhere in the same city would spend about 7,000, 8,000 rupees. The proportion remains almost the same even today. So someone getting into the government stream will not have to spend much.
Okay. Now, the other question that I actually wanted to ask is that from what you have said, it's about 10.5, 11 years of study, which means that someone from technically speaking, maybe 17 years of age or 18 years of age, studies right up to 28 years of age. Is that all? Is it rewarding for everybody monetarily?
Monetarily rewarding, I'm not able to give that equation because I do not know what exactly is monetarily rewarding. But then it is quite good in the sense, like, it's quite good. They could do a very, very good living. They have their satisfaction.
I'm not talking about the top doctor or the guys who make well. They're all really, that's something that nobody can even aspire for. I'm talking about the regular average kind of.
Yes, it is. And as specialists are increasing in number, they're also able to percolate into different areas. So even that way, it is good. Like, you're not concentrated in one area, you percolate into the community, wherein whatever rewards they require, they do get. But again here, Mr. Patabi, I would want to say something slightly away. Maybe it appears a little deviant from what we've been speaking about. I think there is a necessity for us to revive the concept of a family physician, which has been lost. Like those days, you remember every family would know, the doctor would know everyone. Like your father may not know what problems you have or what kind of a constitution you have, but then the doctor would remember. Today, we've lost the concept of family physician. We are coming back. We're trying to get back into that string, like, go back to the family physician concept so that everyone, the family will have a doctor and the doctor will know the reason. There are so many psychological areas which require to be handled. It is not plain. Health is not plain looking at the body and what symptoms are being shown. But there are so many psychological things, and a specialist to whom you go suddenly may not be able to relate all that. The family physician will be able to relate and give a better treatment or give a better guidance. It should be that the family physician looks at the individual first and then refers to the specialist. So there is a necessity that we bring back the system of family physician. I think all institutions across are trying to get into this groove of family physician. In fact, National Medical Commission is thinking of a family medicine course itself, a postgraduate course on family medicine. Okay, that way. Okay, let the Indian medical graduate, MBBS, graduate first and then get into the family medicine concept, have family medicine course itself. So somewhere again, that is a collective responsibility where we'll have to respond to this demand of the community. It's a community demand. And again, it depends on the taker also, not only the giver. The taker also should be prepared to accept that there will be a family physician, go to the family physician. If the family physician is not sought after at all, then nobody will become a family physician. See, this is a kind of a unique situation. A few months ago, I had requests from some specialists. I would not want to name them, but then a particular specialty. They came to me and said, ma'am, it's slowly that our specialty is losing ground. That specialty was considered one of the top specialties just about 5-6 years ago. Now what is happening? Because they are not able to practice. One part of it has been taken by another specialist, one other part taken by another specialist. Whatever was left out was cancer of the region. Even that has been now taken by the oncologist. So ultimately, this specialty has gone in bits and pieces to other subspecialties, and this specialist is finding it difficult. They are not being kind of consulted at all. The patients don't want to see the board. Oh, you're only this. No, I will go there. Or come to the doctor and say, doctor, please tell me that subspecialty. I know at this point, you have done the investigation, you have diagnosed what I have. At that point, your job stops. You now tell me the higher level. So the specialty is slowly dwindling. No taker for that specialty.
What is the point you're driving at?
I'm trying to say, family physician should not become like that.
Yes, I agree.
Next
yes.
5-6 years, we bring in the concept of family physician. So you should not we should not go to that level where, okay, I will not now become a family physician because I don't have a practice at all.
I agree.
So that yeah.
I think it is also got to do with, like I once heard someone say that, no, after I go to a specialist, the specialist should tell you, go back to your doctor.
Yes, we've had specialists like that. I remember I'll proudly recall Dr. Madana Gopalan, who was a medical gastroenterologist. And every time you referred a patient to him, he would tell, the patient would go there and ask, doctor, when do I come back to you? He would only point blank say in a very curt language, don't come back to me. Go back to your family physician. Go back there and ask. If there is a necessity, they will refer you to me. So that kind of probably, all these will have to come in, not exactly the same words, but many things will have to be tied up, and that would give us a wholesome health sector arrangement.
Doctor, one last question.
Yes.
Can second guess your answer, but I don't want you to be diplomatic. Would you advise somebody today who is in class 10, 9, 11 to become a doctor?
Yes and no.
Okay, that's good.
In the sense, yes, it is a good area to work at, but don't think medicine alone is life. Doing medicine alone is not life. That is why I said no also. It depends. The aptitude, the interest, everything matters. Because I've seen students who have come in, they have been forced to join medicine, they were not interested. In our days, medicine, engineering were the only two options available. If you are a good student, you either will have to join the engineering college or the medical college. Things
Or
are
you're
not,
dubbed bad.
yeah, things are not the same. You can find your satisfaction, you can find your mind anywhere. So if someone is really interested, if someone could put in that kind of effort, and I believe medicine is a lifelong learning. You know, yes, you may have to sometime sacrifice your time. I would not say it should not happen. It would happen. If a patient is sick, if your patient is sick, maybe the day you want to celebrate, you may not be able to celebrate. It might be a Deepavali day, it might be a Christmas day, it might be a New Year's day. But then if your patient is sick, you would have to rush. So it is not that kind of a job you can say, okay, keep waiting, tomorrow I'll come and do. No. So right at the beginning, people will have to understand this is a kind of a job, profession or vocation, call it by whatever name. This is where, yes, you will have to keep your own whims and fancies, wishes, whatever desires a little away at times or many times. Yes, it is needed. That attitude will have to be there.
Thank you very much, Doctor. I'll very quickly summarize for our viewers. Dr. Sudha Seshayyan says that the winds of change in the medical profession have begun to blow. There's a lot of change that has taken place in the curriculum. Competency-based medical education is a new mantra. Tomorrow's doctors 5 years from today, will also be equally skillful as much as they are knowledgeable. She says that the quality of the doctors who come out are definitely very, very good. And more importantly, I think one of the principal takeaways is that we need to go back to the system of the family doctor, a doctor who once upon a time used to carry a briefcase or a suitcase with him, would visit patients. Maybe it might not happen that way, but someone who is more broad-based. And last but definitely not the least, I think she was very, very straight on when she said, take up the profession of medicine by all means, but take up only if your heart is there. Thank you very much, Dr. Sudha Seshayyan. It was nice talking to you.
Thank you. I enjoyed it as well. Thank you.